Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of August 11th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. It is that time of year, school is starting, so today we'll be going over some timely information published this month about children and COVID. Then I'll provide an update on some changes at the CDC and potential implications there. So first, let's start with an update on COVID. First, taking a look at respiratory viruses, and this is the percent positive. So this is the share of positive tests for people who go into a medical setting to be tested. So I always want to keep in mind that because we can test at home for COVID, and a lot of people choose to do that, those tests would not be included here. And we could also imagine that for those folks, they know they have SARS-CoV-2, they're not necessarily going to go into a clinical setting to get tested. But with that being said, the majority are still rhinovirus enterovirus, that is in the gray, and an increasing share is SARS-CoV-2, which continues to be increasing in terms of the percentage of positive tests, despite what we said about so many home tests being done. And we know that all of the others are essentially already pretty nil or decreasing in terms of their percentage of tests for people who go to be tested in a clinical setting. And when we take a look at what's going on with SARS-CoV-2 in the wastewater, we can see clearly it is heading up in every region of the United States, with it being the highest in the western region. So that's that teal line, and that's kind of heading straight up, and it's already considered in the high range there. And several others are either moderate or low, but all are continuing to head up at this time, and this is through July 26th. And when we take a look at the epidemic trends, this includes really looking at emergency department visits for SARS-CoV-2, and we can see that almost everywhere across the country is either definitely growing in the darker purple or likely growing in the lighter purple, and this is happening all across the United States. And when we drill down and take a little closer look at emergency department visits, this is categorized by age. I'm going to refer to this a little bit later on today, but as we can see, that dotted yellow curve is just heading straight up when you look over to the far right. And so that is our children, that's 0 to 11-year-olds. They are making up the largest share of COVID emergency department visits and have been for several weeks now. And you can kind of see that some of the others, even the 75 and up, looks to be leveling off slightly there. So we'll see what happens. But with our youngest, 0 to 11 years old, are the most severely impacted here in terms of emergency department visits for COVID. And when we look at hospitalizations, we can see that they continue to creep up. There's a big variability state to state. So I have linked in the post where you can check out what is going on in your state. We know that several states are not actually reporting on all of their hospitals. When we take it in aggregate for the whole United States, this is actually reflecting 82% of hospitals nationwide, and we can see the hospitalizations for COVID are going up, but in some states like Hawaii, it's to a much greater extent than others. California also increasing significantly as well, and then some other states just simply not reporting enough. And so if you're interested in what's going on where you are, you can check out the link in the post. And this continues to be some better news. We have 151 deaths reported for the week ending July 12th. This is still a lot of people. We're still losing people all year round, but the better news is that it continues to be lower than it has been this entire pandemic. So we'll take the good news where we get it. We know that this doesn't mean that people aren't still getting sick. We know that We still have a lot of hospitalizations. We have a lot of long COVID and post-COVID impacts, but at least we can say that the most severe outcomes, death, is decreasing and is staying fairly low at this time. So this is just something that we will want to keep an eye on. So now I want to share this article published in the journal Pediatrics from the American Academy of Pediatrics called Hospitalization for COVID-19 and Risk Factors for Severe Disease Among Children 2022 to 2024. This is an open access article. It's linked in the post, and it was published on August 1st, 2025, so very timely as we head into the school year. What the authors did was use data from COVIDnet, that's part of the respiratory virus hospitalization surveillance network that I report on here frequently, which monitors lab-confirmed hospitalizations associated with COVID. So COVIDnet has an interactive dashboard and data that can be reviewed. I've linked that in the post. And it's important to note that while the data from COVIDnet is used to estimate national disease burden and to understand trends, it doesn't capture all COVID-19 hospitalizations in the country. So just a little more background on COVIDnet. It's a collaboration between CDC, the Emerging Infections Program Network, the Council of State and Territorial Epidemiologists, and selected state and local health departments in the United States that conduct population-based surveillance, according to the CDC. And COVID-19 Associated Hospitalization Surveillance Network, or COVIDnet, is a surveillance platform that collects data on COVID hospitalizations from a defined geographic area that covers a reported over 34 million people and includes an estimated 10% of the population. The COVIDnet surveillance area is thought to be generally similar to the overall US population in terms of demographics. So that doesn't necessarily mean that all the findings are generalizable to the whole United States, but they do collect quite a bit of demographic information as well as clinical data that helps CDC to come up with the COVID burden estimates that they share and that I've shared here a number of times. And it also helps us to follow trends. And COVIDnet, as I mentioned, is part of RespNet, which includes not only the COVID data, but also influenza and RSV hospitalization data. So that allows us to compare the burden of those viruses against one another as well. So 10% of the population, it's definitely not exhaustive. It's not saying that it is the entire country, but it does at least give us a way to estimate burden and to follow trends. So the authors here state that the surveillance system included COVID hospitalizations in more than 275 hospitals in the catchment area, covering again about 10% of the US population in 90 counties across 12 states. And they included all COVID hospitalizations among children 6 months to 17 years old. And they looked at 3,574 hospitalizations over a 2.5-year period. So from October 2022 to April 2024 among children 6 months old to 17 years old. And these were individuals with lab-confirmed SARS-CoV-2 infection and hospitalization. And then they did some deeper assessment to look at risk factors for severe disease among these children who were hospitalized for COVID. And they looked at them in 2 groups, the first one being 6 months to 23 months of age, and the second group being 2 years old to 17 years old. And this is helpful because oftentimes when we're looking at data for children, they're just giving us 0 to 17 and kind of lumping them all into one big category. But when you do that, you lose your ability to see a lot of the details. Like earlier, I shared the graph looking at ER visits by age, and we saw that the largest group of COVID ER visits was 0 to 11-year-olds. but it wasn't broken down any further. And with 0 to 11-year-olds currently having the highest rate of ER visits for COVID, even higher than our 75 years old and up, it really would be helpful to see further breakdowns. The authors here chose to exclude children younger than 6 months of age because they're not eligible for the COVID vaccine, and that was one of the factors that they wanted to look at. But we do know that this youngest population is at particularly high risk, partly because of that reason, because they're too young to be vaccinated. So in that sense, it's unfortunate that they were not considered in this analysis. But since one of the things they were looking at was vaccination status, that's why they weren't included here. But I'll talk more about this in a moment. But among these 3,500 plus hospitalizations, they looked at a number of different demographic characteristics like age, sex, race, and ethnicity. And they got most of that information from medical records or from disease databases, laboratory data, and hospital databases. So they had access to a number of different data sources. Then they also looked at clinical characteristics. So they looked at a number of different underlying medical conditions. And they also looked at COVID vaccine status, which they got from state immunization systems. And they looked at outcomes of clinical severity, which they got from hospital records. So these outcome measures included things like length of the hospitalization, whether or not they were admitted to the ICU, whether they needed respiratory support or some of the more invasive methods of life support, and in-hospital death. If you're interested in the statistical analyses that they did, please check out the article linked in the post. But the bottom line is that they constructed models separately for the 6-month to 23-month-old group and the 2 to 17-year-old group, as I mentioned. And in both models, they assessed demographic characteristics and underlying conditions, and they looked at vaccine status and severe outcomes. And here is what they found. So overall, almost 40% of the hospitalizations were in that younger, smaller age group of 6 to 23 months old. So 40% from 6 months to 23 months old. And so a little over 60% were in children 2 to 17 years old. Hospital rates varied by month by age group, but overall they were highest from November to February. Although I will note that the analysis ended in April of 2024, so it left out that particularly bad summer of 2024. But as we can see, this figure shows month by month from October 2022 to April 2024, broken out into the 4 age groups, which are each represented by one of the lines on the graph. And you can see the age groups defined along the bottom there. And we can see that the heavy solid line at the top represents the 6 to 23-month-olds. So every single month for 2.5 years, by far the biggest burden was among the 6 to 23-month-olds. And then this is followed by the next line down, which is the 2 to 4-year-olds, that dashed line. And then the 5 to 11-year-olds and the 12 to 17-year-olds are the 2 lines closest to the bottom. They're following similar pattern to one another, but overall, 5 to 17-year-olds were hospitalized less than the younger age groups. So that was month by month. And again, we can see that the biggest peaks happened from November to January in both seasons. Now, this figure shows the cumulative hospitalization rates by age. So basically, instead of looking at it month by month, this is looking month over month, adding it up over time. And once again, we can see that COVID-associated hospitalization rates for the 6 to 23-month-olds are by far the highest. Now, the authors also did what's called chart abstraction, where they actually go into the medical records and pull out quite a lot of detailed information. And they were able to do this in about 92% of these children's records. And there's a table in the article, table 1, that goes through a whole lot of detail if that's something you're interested in, but I will go over some of the highlights. So a little more than half of the hospitalized children were male, about 54%. Also, children of color were disproportionately represented compared to their proportion in the population. So using the terminology they used in the study, about 35% were non-Hispanic white, 28% Hispanic, and 23% non-Hispanic Black. So this represents quite a lot of disproportionality here. So again, this is not exhaustive, it's not covering the entire nation, but it is thought to be a relatively representative sample demographics wise. We know that the white population in the United States is close to 60%, but they made up only 35% of the COVID hospitalizations among children. On the other end of the extreme, Black children were overrepresented, being only about 12% of the overall population, but representing over 23% of the pediatric hospitalizations in this analysis. So almost double what would otherwise be expected based on the population. So this is something we have to keep in mind. There are unfortunately significant racial and ethnic disparities that we have been seeing since the beginning of the pandemic, and it has been quite pronounced amongst children. And this is persisting, even though we so-called have the tools. So more about that in a moment. First, let's talk about underlying conditions. So even though the conclusion that they put in this study is framing their findings as most hospitalized children have at least one underlying condition, I do think the nuance here is actually very important, so I'm going to walk through it. So it is true that overall, 58.9% of children hospitalized for COVID in this sample had at least one underlying medical condition, so a little over half. Of those, 25% had exactly one condition. And even more striking is what we clearly see here in figure 2A, which is that when you look at the 6 to 23-month-old group, so they're on the far left, only 41.8% had an underlying condition. So in other words, almost 60% of children that were hospitalized for COVID who were 6 to 23 months of age had no underlying medical condition, almost 60%. So this is significant. And in the 2 to 4-year-old group, which as we saw before is the next most hospitalized group, about 40% had no underlying condition. So significant. So in the younger age groups, these are the age groups that bear the disproportionate burden of COVID hospitalization compared to the other pediatric age groups. These are also the groups that are less likely to have an underlying condition. And I'll get to why that's important in a moment. But first, let's take a look at figure 2B, which shows us a little more about which conditions are most relevant here. So here we see those same 4 age groups across the bottom. So we have these groups of bars for each of the 4 age groups, and this represents the different underlying conditions. So looking over to the far left at that cluster of bars there, remember, this is the age group where almost 60% don't have any underlying conditions. So this is only looking at the 40% who do. And the most frequent underlying condition by far is in that light turquoise color, and it is prematurity. So babies born premature. This is not an uncommon underlying condition. It actually affects about 10% of the population. So again, most of the babies in this age group have no underlying condition, and for those who do, the most common reason is prematurity, which is a relatively common underlying condition that people may not even think of as an underlying condition. So when you look at the other 3 age groups broken out here, asthma, which is in that orange color, is either the number 1 or the number 2 underlying condition. We know how common asthma is, a very common childhood condition, and it's either the first or the second most common underlying condition among children hospitalized for COVID. So this is certainly striking and concerning. And then neurologic disorder is either first or second in each of these age groups. And those include things like seizure disorder and cerebral palsy. Regarding vaccination status, 96.2% of these children who were hospitalized for COVID were not up to date with the COVID vaccine. So 86% of them had no vaccine within the 12 months before they tested positive for SARS-CoV-2, and 10% had a vaccine within the previous 12 months. but they weren't up to date. So that means that they didn't get their full primary series. So this would be for the little ones who did not get their full primary series, most likely. So there's a lot of detail about vaccination in the article, but when they looked at specific medical conditions just to see who was getting vaccinated and who wasn't, the highest proportion of children with up-to-date COVID-19 vaccines included those who are immunosuppressed. But even then, it was less than 10% of those children who were vaccinated. Only 4.5% of children with asthma got vaccinated. Only 3.1% of children who were premature were vaccinated, and only 5.2% of children with neurologic disorders were vaccinated. So one, we seem to be ignoring the fact that all children, whether or not they have an underlying condition, are at risk for COVID hospitalization. And two, we're doing a terrible job of protecting those who do have underlying conditions. We know that the list of underlying conditions that make a person at risk of a bad outcome is a very long list. And I continue to find time and time again that people don't think they're on that list, but they are. People may also not think their child is on that list when they are. Obesity is on that list. Asthma is on that list. Prematurity is high on that list. And that is an underlying risk factor all the way up till 23 months. So these are common. We need to be especially concerned about them, and we need to be protecting all children. Now, just a note on severe COVID disease, and this was particularly alarming. Over 25% of the children hospitalized required ICU admission. So 1 in 4 of these hospitalized children had to go to the ICU. This includes 31% of those aged 12 to 17. Shockingly, almost 1 in 3 of hospitalized children required high flow oxygen or mechanical ventilation, so they needed support to breathe. 10 of these children required ECMO, which is a type of life support when the heart and lungs are failing, and 14 of these children died. So needless to say, these are horrible outcomes. Now, who is at risk, at highest risk of severe outcomes? So first, looking by age group, about 40% of the children 6 to 23 months old had severe COVID. And the risk of severe COVID in this younger age group was highest among children with chronic lung disease, including asthma. In the 2 to 17-year-old group, about 35% had severe COVID. And among that group, the highest risk was among those with chronic lung disease, not including asthma, as well as diabetes and neurologic disorders. Severe COVID was also more likely among males and among those with cardiovascular conditions. Now, once again, children under 6 months old are known to be at much higher risk of ER, hospitalization, and severe outcomes from COVID. They're hospitalized at a much higher rate than older infants and children. And they also are much less likely to have an underlying condition diagnosed yet. So the authors clearly note that if they had included 0 to 6 month olds, that would have skewed the results towards higher hospitalization rates and fewer underlying conditions. But even with the under 6 month olds excluded, this is all very concerning. And as we've seen, the next group, 6 to 23 month olds, are the most disproportionately impacted in this analysis, so our youngest. So bottom line is children continue to experience severe COVID disease. This is not limited to children with underlying conditions, but certainly an increased risk of severe disease was associated with certain conditions, and these include chronic lung disease, cardiovascular disease, diabetes, neurologic disorders. The authors conclude that increasing COVID vaccination among all eligible children, and especially those with underlying conditions, would reduce pediatric COVID hospitalizations and other severe outcomes. So one of the limitations, as I mentioned, is this covers about 10% of the population. We're not completely sure how generalizable this is, but the results are not different from the national trends we've looked at here before. And the additional nuance and detail, I think, in this article is helpful. And I think this information all makes it very clear that the recent changes to COVID vaccine recommendations that came from HHS Secretary RFK Jr. are not supported by facts or reason. If we're looking at the facts, we would see that pregnant people should absolutely have access to the vaccine to protect the group which is at greatest risk of hospitalization, which is 0 to 6 month olds. And all children, irrespective of whether they have a diagnosed underlying condition or not, should have access to the vaccine, because we can see that a significant portion of hospitalized children do not have any underlying medical condition at all. And remember, this is only looking at hospitalizations. And even with that, many of those hospitalizations ended up being severe. A quarter of them went to the ICU. This is devastating for children and their families to have to go through and come back from. But this doesn't even count ER visits. It doesn't count long COVID. It doesn't count post-COVID impacts. And all of these can be reduced with up-to-date vaccination. Also, we know that the simpler the guidelines, the more likely they are to be followed. So the previous guidelines, everyone 6 months and up is eligible, aligned with the flu vaccine recommendations. And that made a lot of sense. And it ensured that access would be preserved and that the instructions would not be confusing like they unfortunately are now. So sadly, this is not the logic that's being used by the current administration, and instead, confidence and access are steadily being undermined. The guidelines now basically include so-called shared decision-making, which will require that you have a primary care provider that you trust and that you can share decision-making with. So I would strongly encourage a shared decision of staying up to date. Now, as I discussed here before, those changes to the vaccine recommendations were made outside of the normal process. It appears they were made unilaterally by the HHS Secretary, among other moves to destabilize public health, including the firing of the 17 members of the CDC's advisory committee, the Advisory Committee on Immunization Practices. There has been one meeting of the newly seated body that was disconcerting, to say the least. I covered that in some detail in a prior briefing. But last week, we got news of further removal of critical expertise from the CDC's process, and that is that a number of expert liaison organizations have been notified that they're no longer allowed to attend the ACIP's work groups as they have in the past. There are about 30 organizations who received an email informing them that liaison organizations are special interest groups that are expected to have a bias based on who they represent. And this was the stated reason why they would no longer be allowed to be part of the ACIP's work groups. So these are groups that have provided clinical and scientific expertise to help protect the public and to have more informed discussions to guide recommendations. And they've been doing so for decades. Includes groups like the American Academy of Pediatrics, the American Geriatric Society, the Infectious Disease Society of America, among others. These are expert organizations. An HHS spokesperson once again offered vague rhetoric about how these groups are biased and won't ask the hard questions. So I don't know if the administration has come up with a new definition of the word bias, but we need experts, and we need experts who care about the populations that they work with, which is the voice that they lift up, which is where their expertise lies. That is who we need being part of these discussions. And this does not equate to bias. Anyone can ask hard questions. We need people who can actually answer them with facts and evidence. And right now, there is no indication of how that is going to happen as the CDC and the ACIP become further undermined and isolated and under the influence of politics rather than science. The entire vaccine evidence to recommendations process is being eroded, and recommendations are being thrown on websites and posted on social media, completely circumventing any kind of process. The newly seated ACIP members have a number of conflicts of interest that are seemingly being ignored, apparently because their ideology appears to align with the current administration. So again, what is our working definition of bias? I will say that a Senate inquiry has been opened up into the firings of the ACIP members, and to seek additional information on the new members and how they were vetted, but we'll have to see how that is going to go. In the meantime, we do finally have a CDC director. The US Senate confirmed Susan Menares to head the CDC. This is the first time we've had a CDC director to be confirmed by the Senate, and that's because of a new law passed in 2023 requiring Senate confirmation. She's also the first person to serve in the role without a medical degree in over 70 years. She is a microbiologist and an immunologist, and she seems to be highly regarded by a number of leaders who say that she's a longtime civil servant who is committed to science. She was the acting CDC director from January through March of 2025, so just a few months before she had to step down because she was selected for the director role, and those are the rules. So it was during that time when we did not have a CDC director that HHS secretary made some apparently unilateral, non-fact-based changes to the COVID vaccine guidelines. In her confirmation hearing, Menares said that one of her top priorities was to rebuild credibility and be more public-facing and accountable, and I quote, ensure all recommendations are backed by publicly available gold standard science. So we certainly look forward to that. In the meantime, it is more important now than ever that we stay focused and that we avoid being in denial about all the things about the realities of COVID, about the impacts of dropping vaccination rates, not only for COVID, but for all childhood vaccines, which I talked about in quite a bit of detail last week, that we stay vigilant and do what we can to protect ourselves and our loved ones. With folks heading back to school, it has been demonstrated that mixing at schools helps drive community transmission. So we want to do all we can to keep not only our students safe, but also our teachers, administrators, parents, households. We need to ensure that our schools are as safe as possible and that we continue to follow our best practices for reducing the spread of disease, especially ones that are transmitted by the respiratory route. And remember, gathering outdoors is almost always safer than indoors, not foolproof. So we're still going to be careful, especially where it is crowded. But outdoors is generally going to be safer than gathering indoors. When you are indoors, it's important to improve indoor ventilation. That can be with opening windows and doors, especially across the room from each other, and also making use of those central air HVAC systems, as well as filtration like HEPA filtration systems. And when you are in crowded indoor environments, consider wearing a high quality filtration mask. This is going to give you a great layer of protection. And especially now when we know that cases are going up, this is something to certainly keep in mind, even if you aren't masking as much as maybe you had been. This is a time to do it, especially if you are in crowded indoor environments or places with poor ventilation. And let's try to avoid infection and reinfection. We know that every new infection is an opportunity for not only getting sick, not feeling well, losing days of school, losing days of work, spreading it around to your loved ones, but also those potential long COVID and post-COVID impacts. If you don't feel well, please test to rule out COVID. This is the best way for you to get access to treatment in a timely fashion, which is our best option to reduce that virus from replicating and prevent some of those worst outcomes. And it's also the best way for you to know that you need to take precautions to protect those around you, those you work with, those you live with. If you don't have a primary care provider, please get one. Remember to eat a balanced diet, stay well hydrated, try to reduce simple sugars and processed foods, artificial ingredients, quit smoking and reduce that alcohol intake. Remember that if you don't feel well, it's best to fully rest and recover. You deserve that, and it also can prevent, it looks like, some of those post-viral sequelae or consequences from happening. Otherwise, get some regular physical activity, get some fresh air, we're getting some beautiful weather, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we will see you again next Tuesday at 10 a.m.